Thank you for getting up here on this hot summer morning and coming in to hear Dr. Wu's talk. I'll invite you to move up if you don't mind. Apparently we don't have a the microphone working, and so you might hear better, and it's a small group at this point and leave room for others who might be coming in a few minutes late. So we're really honored to have Dr. Anna Wu, who's from the Department of Preventive Medicine, and she's done some great work epidemiologically and also some intervention work in a number of different forms of cancer, and she's going to speak to us today about some of her work relating to some botanicals, soy, green tea, and breast cancer. So we're very excited to hear your talk, Anna. Thank you for speaking to us.
Thank you.
You can put that in your pocket.
I don't have a pocket.
Can you put it on your waistband?
I don't have that either. Should I just hold on to it? Oh. And what is the advancing thing? Okay. Okay, well, good morning, everyone, and thank you for coming, and thank you for the invitation to be here. So before I actually start the talk, I just want to mention that I'm a cancer epidemiologist by training. And I actually got into the area of doing soy and green tea only because these were observations that we found in our epidemiologic studies of breast cancer. And I really, the studies that I was working on in breast cancer was really to try to understand what are some of the factors that can explain the traditionally much lower breast cancer rates in Asia. So the breast cancer case control study that I've been conducting in LA County, in Los Angeles County, in the last 15 years was really motivated to try to understand why did Asians traditionally had about 1/6 of the breast cancer rates of Western populations. What happened with migration that the rates actually increased quite steadily, and what has happened in Asia in the last 30 years that had prompted this steady rise. So that was really the motivation of my case control studies of breast cancer. And I really got involved in soy and green tea because these were the observations that we found in our case control studies. And we wanted to sort of do these additional studies to try to understand the observational studies, because there are many things that one cannot control for well enough in observational studies. So that's really the background. So in the session on soy, what I want to review with everybody is really the terminology, which is incredibly confusing. Why we're interested in it, what are some of the findings that we have from the observational studies in terms of soy and risk of breast cancer development, and then soy in women who already have breast cancer. And then finally, I'll touch on some of the clinical trials that others and we have been conducting, and where are we in that. So the literature is confusing to me, in part because the words are used interchangeably. Phytoestrogen is a class of compounds that includes isoflavonoids. Soybeans have many constituents, including isoflavones, and it just happened that isoflavone is the part of the soybeans that have been studied very well. There are many other constituents of soybeans that are probably equally interesting. It's just that they never got studied as well. In traditional Asian soy foods, you can sort of put them in two categories: the fermented soy foods and the non-fermented soy foods. And those are used, as I think of Asian soy foods, like cheese. You simply add them in foods. So that's how I think of traditional Asian soy foods. Then there's a whole category of Western soy products before the interest in making money out of soy. So those things are added to cereals, to tuna, to all kinds of things, and they would be soy flour, soy protein concentrate, and the vegetarian meats that you can get from Loma Linda, as an example. Then people got interested in soy, then they make all these second-generation soy foods that has the word soy in front of it, but you have no idea really what is in it except there's a lot of sugar. So there's soy cheese, energy bars, etc., etc. Then there's a whole class of soy supplements that are supposed to be sometimes used as bioidentical, which I really dislike the word, but they are just used for various menopausal symptoms. So it is important for me to remind you that in fact the observational studies that we're talking about that really got people interested is really based on traditional Asian soy foods. We have no idea what are the health effects of all these other second-generation soy foods, or even soy protein products, because that's really difficult to study, okay? So just briefly, the interest in soy is in part not only because it's eaten in Asian populations, and Asian populations happen to have lower risk of breast, prostate, colorectal cancer in Asia, but because it has this structure that actually looks a lot like 17-beta-estradiol. And as a result, it binds quite well to ER-beta and not as well to ER-alpha. And there's a whole host of both hormonal and non-hormonal properties, which I will not go into because in the last 20 years, because of the interest in soy, there's been just, hundreds, thousands of papers on these things, in dishes, in cells, in animals, whatnot. But the important thing is soy actually looks like a SERM. It acts like a SERM in many ways. So very briefly, I want to say that there is actually, in terms of soy and breast cancer, in the last 20 years, there's been at least 30 plus studies and many, many more meta-analysis on the subject, okay? And the meta-analysis are very deceiving in many ways because many of them simply copy the last person's and they don't go back and actually review what the studies are. So what I wanted to emphasize is that if you're actually interested in the subject, do not rely on people's meta-analysis. So the way I have done the meta-analysis results that I am going to show you is really considering several study design issues. One is whether the studies that we're talking about are case control studies or prospective studies. Case control studies, information on soy, are collected from people after they've been diagnosed with breast cancer and a comparable control group. The prospective studies are studies that were following up individuals and they happen to have information on soy because, as you can imagine, very few prospective studies were actually designed to study soy. So then the information on soy, there are sort of two kinds of studies. In many of the older studies of breast cancer done in Asian populations, the food frequency questionnaire would have questions on soy, miso, rice, fish, salt intake, and so there are these what I would call opportunistic ways of analyzing the data. You simply ask the question because it was already there. Then there are studies that were actually conducted because they were interested in soy. So the assessment of soy intake was much more complete. So what I have really only considered in the meta-analysis was studies that actually try to have a fairly complete assessment of soy intake and not what I would call opportunistic studies. All of us have done them. There's nothing wrong with them. But I think it's important to understand what the source of information is. And we also wanted to make sure that we actually have adequate information in terms of various things that one ought to adjust for. In the cohort studies, some of them not only have information on intake of soy as a self-reported assessment, but some of them also have biospecimens, including urine or blood, where they can actually measure soy isoflavone. And so those studies are also included. And so the way I've done the analysis is considering both study design, whether the studies were conducted in Eastern or Western population, because in fact, the intake is so different that it's not meaningful to put them together. Menopausal status and hormonal receptor status. Now, one of the things I want to simply mention is that in dietary studies, as in many other studies, very often individuals analyze the data and present them by quartiles of intake, quintiles of intake, tertiles of intake. Those words are not very meaningful unless you actually know what those quintiles and quartiles are. So as an example, in studies conducted in Eastern population, the lowest quartile is often about 2 milligrams of isoflavone. The highest quartile is usually, let's say, over 20 milligrams of isoflavone. In Western population, they can create a quintile and a quartile. But guess what? The quintile, the lowest level is something like 0.001. The highest quartile is maybe 1 milligram. So they are not the same things. You know, and the fact that they either see something or they don't see something is not meaningful. And unfortunately, individuals analyze data using quintiles and quartiles and essentially cut points without ever actually specifying what those cut points are, okay? So these are studies now that I've summarized on the left-hand side and on the right-hand side, case control studies and prospective studies done in Asian population, where roughly the lowest category is about less than 5 milligrams of soy, and the highest category is 20 and above. So without going into the details, you can just sort of look at it and sort of see that in both groups of studies, there's about a 17% of 20% reduction between the highest and the lowest, okay? And the results in pre- and postmenopausal women are not different. There's a small subgroup of studies that have also looked at ER-PR status, and again, there are fewer studies, but in general, the results are not different. Now these are the studies from Western population, where they also look at low versus high. So I'm reminding you that the low is much, much less than 1, and the high is rarely much more than 1. So the fact that they see absolutely nothing, I'm actually comforted. I will be really worried if they did see something, but some of them do find something, right? Okay, so these are the studies on adult soy intake in Eastern and Western populations. In addition, there have been a few studies that actually specifically collected information on soy intake during earlier life. And earlier life is either during childhood, adolescence, but essentially not talking about adult soy food intake. 4 of these studies are case control studies, and all 4 studies, including ours in LA, really did see a protective effect. The only study that is a cohort study that was really done to look at soy intake and other things was a large cohort study from Shanghai, and they actually did not see any protective effect of early life soy intake. And to me, it is actually really important to continue to follow up this cohort, which we will be able to really understand what is going on, because that's actually the only cohort study that have information on earlier life soy intake. So the fact that we all see it in the case control study, but it's not there in the cohort study in China, actually bothers me. But I'm sure this will be continued to be followed up. So while all of this was happening in the last 20 years, and people were thinking that soy is the panacea of all, there were concerns about whether soy was actually safe, in part because it looks like an estrogen. It sometimes acts like an estrogen. So there are many safety concern type studies here, and that have been published, but I only want to mention the 2 that really has been publicized and really was the basis for many clinicians telling the patients not to eat soy. The first was a very small pre-surgical study that was done in the UK, where they gave women, between the time they were diagnosed of breast cancer or going to get a breast biopsy and the diagnosis. So it was a pre-surgical study of either people getting a breast biopsy because of benign breast disease or breast cancer. So one group was given 60 grams of soy and the other was nothing. And they looked at Ki-67, which is a mark of cell proliferation. They found that the soy group had higher cell proliferation. So to them, that actually suggests that it's a bad thing. So that study really sort of set the tone that soy is a bad thing, okay? Then the next group of studies that really got people very nervous was a series of studies by Bill Hefrick in Illinois. He's a very good scientist. His lab looked at these athymic oophorectomy mice models. They use all kinds of soy products, and essentially they published at least 20 studies in different animal models where soy was bad. Soy negated the effect of tamoxifen. Soy negated the effect of aromatase inhibitors. So that, again, really set the tone that it might be not a good thing. And that really was the basis, I think, that a lot of physicians tell their patients not to eat soy if you have breast cancer. So, in fact, because of those studies, women were not eating soy, if they have breast cancer. And in fact, that whole area just sort of stopped. People got very nervous. So it took a while for these studies to now surface, because they were either done before all the scary things happened, or I don't know. Anyway, so there were a few studies that continue to look at what is the effect of soy in breast cancer patients. So 6 of these studies actually had information on soy intake before breast cancer diagnosis. So these were really case control studies that collected the information as part of the case control studies and then followed the women over time to try to look at whether the outcome differ for those who actually ate soy before they were diagnosed and those who did not eat soy before diagnosis. So that's one group of study. Then there were 3 studies that specifically look at soy intake after breast cancer diagnosis. 2 of those were really trials on breast cancer diet, the Will study and another one that I forgot, and then the Shanghai cohort. So these studies actually specifically asked women what were their soy intake after breast cancer diagnosis, and 2 of those studies actually had repeated measures asking them about soy intake after diagnosis. So that's pretty much the data on soy intake after breast cancer diagnosis. This I'm actually summarizing for you because this is actually the most detailed study on outcome in breast cancer patients who ate soy after diagnosis. So the orange things actually just show you the 3 studies, and you can look at the upper versus the lower comparison, which is greater than 10 versus less than 4 in the various studies. So this study was done in Asia, the ABCPP study. That's the Shanghai study. And then the LACE, the Will, those studies were actually done in the US. So you can see that at least from this type of analysis, with about 5 to 8 years of follow-up, there may be a hint of benefit, but certainly not much of a suggestion that is bad for you. So this is, to me, the strongest data that maybe soy is actually okay for breast cancer patients. And I combined the 6 studies with information on soy intake before diagnosis and soy intake after diagnosis to look at total mortality and breast cancer mortality and recurrences, and that's what we find so far. So while all this is happening, with the initial euphoria that soy is a good thing, and then, there's been many cross-sectional studies trying to understand if soy is good or if soy is not good, how is it working. So most of these studies look at two endpoints that are well established to be endpoints that help us understand breast cancer. One of them is circulating hormone levels, and the other is mammographic density. So this is a pooled a meta-analysis done by Hopper and co-workers that looked at 47 randomized trials of various types of women, pre-menopausal, perimenopausal, postmenopausal, and these women were put on various regimens of soy, from foods to whatever. Most of them were at least 4 weeks. The summary or the conclusion from these studies is there is no obvious effects on hormone levels, good or bad. But it's also very difficult to really interpret these studies because they were so small. The number of individuals in the studies was small. Endpoints were measured in various ways. So there's a lot of studies sort of funded in the early stages without a lot of thought onto what kind of studies do you actually need that are adequately powered to study it. I mean, we also contributed to this mess, so I'm not blaming others. Partly it's because it is very difficult to do a large enough study to look at this, but they are very difficult to do. Then there's a few studies looking at mammographic density, and again, all I would say is that the studies were not very illuminating. They were simply, but I would say that the conclusion for me from these studies is, one, if there is another dietary agent out there or whatever it is that out there that we're interested in, we really need to do adequately powered study. Otherwise, it's not helpful. Now, so the last bit that I want to mention on soy is, so we have the observational studies, we have the small clinical studies that look at hormone levels and mammographic density, and then there are a few studies that actually look at cell proliferation in breast tissues. As I mentioned, the study that originally got everybody very nervous is the small study that has breast tissue, and then they look at cell proliferation. So there are 4 more of these studies, and as you can see, the number of individuals in all of these studies were also very small, and they were inconclusive. The biggest study was actually published in 2012 by Dr. Khan in University of Chicago, or Northwestern, and this was a study that they gave women a lot of soy. They were given 235 milligrams of isoflavone in a capsule per day. So that's a lot, right? Because in the Asian population, most of them were eating somewhere between 25 to 50 at the higher end. And it's a study with a mixture of women. So if under the subject characteristics, you can see that about 70% of the women in the randomized to the soy and the placebo group were women who did not have breast cancer, but were for high risk for various reasons. And then they had a small group of women who had breast cancer. And the bottom line of this study is there was no demonstrated effect that was statistically significant, except that in the soy group, in the premenopausal women, their cell proliferation actually went up at the end of 6 months after soy intake. So this results from this study was used as a cautionary measure, again, that soy may not be so good for you, especially if you're premenopausal. There are all kinds of, these are really difficult studies to do, and I will say that really trying to get at an accurate measure of cell proliferation in premenopausal women means that you actually need to be getting it at the same time in the menstrual cycle. And that is not so easy to do. So, one can interpret the result as one wish, but this is the biggest study. We were funded about the same time this study was published, a soy treatment study in high-risk patients. And in fact, our study was funded in part because of the studies that were starting to surface that soy was not dangerous for women with breast cancer. So we put in a study to the California Breast Cancer Program to try to look at soy intake in women who already have breast cancer or at high risk of breast cancer. And so the difference between our study and the one that I just showed you from Dr. Khan is that we're using a much lower dose of soy. We're using 50 milligrams of soy isoflavone. And instead of a 6-month study, the women in our study were actually on soy for 12 months, or on the placebo for 12 months. They came back every 3 months and gave us blood specimens and a short interview that we actually monitor various things. And the outcome of our study is breast MRI and density and breast cell proliferation. The study is done, but I don't have any results to share with you because we're still analyzing the data. But this is essentially the target population. They either have breast cancer, but they are not taking tamoxifen, or they have already finished the tamoxifen or aromatase inhibitors, or they're high-risk patients. And these are the eligibility. So essentially, that's what they came in. They came in, they gave us blood specimens, urine specimen. We did body measurements, MRI, mammogram, breast biopsy. And so all of the data is now, we're either getting it back from the lab or in the midst of getting it back from the lab. And I just want to mention where we got these women. They're from the Norris, or from LA County, or from the Army of Women. So the bottom line is that we enrolled 108 women, and 12 of them withdrew over time. And I don't know which one is treatment A or treatment B, but these are the women who ended up with the full complement of data that we can analyze. And so you can see that the age, most of them, 80% of them are either non-Hispanic whites or Hispanics. The age and menarche parity is comparable. And in our study, over 70% of them are actually women who have breast cancer, who had breast cancer, or who had already finished treatment, or are not taking any of the hormone therapy. But there is a small group of women who are high-risk women, okay? And so hopefully we will have results by the end of the year. So that's sort of all I'm going to say about soy. So I think certainly the observational data from Asian populations would suggest that whether we're looking at risk of breast cancer or among people who already have breast cancer, there appears to be a consistent inverse association suggesting that soy is okay. In the Western population, there's no data. And so I think one of the things that is of importance is that in the last 10 years, there's many Western population individuals who are eating soy either as foods or supplements. And so that data, that type of study needs to be done to actually understand what are the effects. And I think it will be very difficult to study that using questionnaires. So I think you will really need to have biological specimens where you can actually measure urinary or blood levels of soy. And fortunately for soy, we have a very good biomarker. But those studies have not yet been done. And then I think all the cohorts that can be followed up, both in terms of the childhood soy intake as well as outcome, those studies will be continued. And so I am not going to do anything, I'm not submitting any applications on soy until I see the results from my study, because I don't want to get myself in another hole. So, so that's all I want to talk about soy. And I can either answer questions before we move on to green tea. Yes?
So since the difference between the Asian women's risk of cancer is very different with other races, how you can just differentiate that this is not a genetic versus, the food they are eating? How could you just relate that this lower case is related to the food?
Well, the reason is because Asian women who migrate from Asia to the U.S., U.S.-born Asian women have rates of breast cancer that are as high as U.S. whites. So it's not the genes. You look at Japanese in Hawaii, their breast cancer rate is just as high as white women in Hawaii, unfortunately. So what we would like to do is try to understand what is it that used to protect Asian women and reverse that trend. Because if it is modifiable, that means that whatever Asian women used to be doing, that strategy can be used in other women. I mean, if the rates had not been increasing in Asia as well as among U.S.-born Asians, then yes, there may be a genetic component. And there may still be a genetic component, but it's not going to be explaining the six-fold difference.
May I ask one more question? And the purpose of this research is to show that this soy is okay, or it's going to just have a good effect on the people who have it?
In the beginning, in 1995, when everybody was interested in it, the idea was to show that it was good for you. Then the table turned. All these studies saying that soy is bad for you, it's just like an estrogen. Then people start backpedaling. Maybe what we want to show is it's not bad for you. My goal is really to just to understand what is soy doing. I don't know whether it's good or bad for you. I think the data would suggest that if you're eating the soy food, the food itself, I think is okay from all this data. I don't think it's confounding because I have yet to figure out what is the confounder that is so consistently seen in these studies that can explain it. Because people will always say it's just being Asian. I said, well, you tell me, what is it about the Asians? I don't know what it is. You know, so I think the food itself, the data is showing that it is okay. But because the intervention studies are not using foods, the intervention studies are using this whole range of second-generation products out there that has the word soy in it. I don't know what it does. The animal studies are suggesting that highly processed soy food is different. I don't exactly know what it means, but that's what the lab studies are suggesting. So my recommendation for myself and people that I know when they ask me is eat the food. You know, eat some tofu, eat some edamames, eat some traditional Asian soy foods. Don't go eat chocolate-covered soy nuts. That's not the point.
I'd like to know where I can find those.
Yeah, right.
You know, but that's the problem. You know, when you're trying to then look at, you know, soy cheese or, you know, soy whatever, that's not what the observational studies are suggesting. That's what the data is. So we start doing trials using all kinds of things that is not helpful because it's not going to help us understand the observational studies. The unfortunate part is because you need a placebo group. And it's very hard to do dietary intervention studies with food.
And what do you think about medications like estrogen, which the main ingredient?
There is no data. I don't know what the data is. There is one study, there's a Canadian case control study that actually collected all kinds of information on soy supplements, including estrogen, and their data suggests in their case control study that those agents are okay. They actually saw a reduction in risk in various subgroups. So, but that's the only study, and there are all kinds of issues one can find with, you know, I mean, I think it's a solid study, but it's the only case control study I know that specifically asked about those agents. But it's complicated because women who start taking those agents, you also have to actually make sure you know what else they're taking. So, I mean, I would say that that's the only study I know out there that actually specifically collected the data.
Thank you.
Okay? Yes?
I've heard that Asians can metabolize or digest soy foods differently than Westerns. There's a breakdown in the gut.
Yeah, so people have looked at equal status. So the equal status is really whether if you eat soy, it gets in soy, the three constituents that people have been studying is genistein, datesin, and glycine. The datesin gets metabolized into various metabolites so that you are either an equal expressor or a non-equal expressor. The prevalence of equal expressor is about 30% in Western populations and about 50% in Asian populations. Even after 20 years of doing these studies, nobody can agree whether, in fact, other components of the diet actually affect whether you become an equal expressor. I have a lot of issues with the studies that think that whatever they find is only in the equal expressors, so I'm not a strong believer in it. But those studies are also very small. So unfortunately, none of the observational studies had the biological specimens that you can actually look at whether the effect that you're seeing are actually among women who are equal expressors. So I think in a multi-ethnic cohort study, they have an opportunity to do that. And maybe that's something they could do, or the Shanghai cohort study. So I think those would be the types of study where you can actually really address it. Okay, so we'll move on. What time is it? Okay. So green tea is easier because there's far fewer studies. And so it will go quickly. So what I want to sort of, again, is sort of the same thing. We got interested in green tea really by accident because green tea was one of the dietary agents that we asked. We also asked about black tea. We asked detailed questions on caffeine, actually. And so the interest in green tea the interest in tea really started in the 1980s. There were a whole series of studies on breast cancer and prostate cancer on the effects of tea. So early on, and in fact, the IARC actually wrote a monograph on tea and caffeine. But then people start finding positive associations between black tea and breast cancer and black tea and prostate cancer, and then the field just sort of stopped. So it's again another one of these studies where, there was a lot of initial interest because there were very sound biological properties why one would be interested in it. The data didn't quite fit people's hypothesis, and also because they recognized that all the effects that people were finding on tea in animal models and cell cultures were using levels that were much, much, much higher than what one would get from ingesting. So then those studies, so anyway, we got interested in it because we observed it in our case control study. And the good thing with studying Asian populations in the U.S. is that you really have a mixture of Asians who adhere to some Asian lifestyle as well as some who really don't. So unlike studies in Asia, for example, where everybody is taking it, so everybody is drinking green tea, you actually don't have a real non-drinking population. So in our studies in the U.S. is actually very helpful because we really have people who don't eat soy, who don't drink green tea, who don't drink tea, period. Okay? So we are really at an advantage in that we really have a clean population of either non-consumers or consumers. And I think that's one of the reasons why we were able to see some of these things in our study in LA. So anyway, just a reminder that both black tea and green tea comes from the same tea plant, and black tea is consumed, in the most part of the world. And the really difference between black tea and green tea is that black tea is fermented and green tea is not. And because green tea is not, the actual polyphenols in the tea are pretty much captured in green tea but are not in black tea, or they get converted into those other words that I can't say. Okay? So in a cup of black tea and green tea, they all have catechins. It's just that there's more of it in green tea. Okay, so it's not that black tea don't. It's just that there's less of it. So this was the meta-analysis that really got people, thought, okay, there's black tea, there's absolutely nothing, it's flat. There is no association. And in fact, most of these populations in Western, that were done in the West, there is no green tea intake, or they didn't even ask about green tea intake. They simply asked about tea. So if you only ask a question on tea, if you're doing a study in the UK, you assume they're just drinking black tea. So that's sort of how these studies were done. Some of them, of course, they may be drinking herbal tea or green tea, but they didn't really specifically ask. This is a meta-analysis on green tea and breast cancer. There are far fewer studies. So there are studies really done in Japan, studies done in China, and the results are a little mixed. And it's especially mixed because, as I said, it's very difficult to really understand what's going on in Japan when they really don't drink anything else. So, the baseline group is everybody is drinking. So some of the comparisons is between people who drink, the lowest category is less than 1 cup a day, and the highest category is 10 cups per day. Whereas in our study in LA, the no category is really people who don't drink green tea, okay? So anyway, the data is a little confusing. So because of the fact that we found these in our case control study in LA, back 10 years ago, I was also working with Dr. Mimi Yu, who was here at that time, who had a large cohort study of Chinese in Singapore. So we decided to look at tea intake in her Chinese cohort study in Singapore because Singaporean Chinese are like Asian in the U.S. Some of them drink green tea, some of them drink black tea, some of them only drink coffee. So in the first study that we did, these are now cross-sectional study, we found that the regular green tea drinkers, their blood estrogen was about 15% lower. The black tea drinkers, their estrogen level was actually higher. And then we currently have we have a bigger study now from the same group of women in Singapore in the cohort, and there's still suggested to be some effect of green tea, but much weaker than what we initially reported. The same time, we had a mammographic density study from Singapore, and this again is a cross-sectional study. In the cohort, we had women who were participants in this cohort study, and at the same time, or around that time, actually had a mammogram done as part of their mammography screening project. So we linked up those two groups of those two cohorts, and what we found in our study was that the individuals who were green tea drinkers happened to show slightly lower mammographic density. And the two, if it is real, 2 to 3% is pretty much what you would see if someone was taking estrogen, EPT. So if you actually were not taking any hormone replacement therapy and you start taking hormone replacement therapy, most of those studies show that the absolute level of mammographic density may go up about 3 units. So these are not small differences if they are real. So because of those observations, we got a pilot study funded by the Norris Cancer Center, a Whittier study, to actually look at in the green tea trial whether we would see changes in hormone levels as well as lipid and glucose related markers. So this was a study where we randomized women. These are now healthy postmenopausal women who were not green tea drinkers into 800 milligrams of ECGC, which is roughly 10 cups of green tea, 400, which is about 5, and then the placebo capsule. And again, this was a study that we used capsules and not green tea, okay? And we started this study just at the time when the reports of liver failure with green teas, dietary supplements were published. And in fact, the FDA halted all green tea trials in the U.S. at that time until they can sort out whether it's really green tea that was causing the liver toxicity. And as a result, in our study, we added all the liver enzyme markers so that they had to have normal or not abnormal liver enzymes at baseline, and then we monitor the liver enzyme. So these are 3 groups of women. They are recruited from county and North campus. And what we actually found was that none of these things changed, and it's a short study. It's only for 2 months. And the only thing that really sort of changed was the fact that the groups taking ECGC, their urinary catechin levels went up. These are results in terms of changes in serum hormone levels after 2 months of intervention. And so we actually did not see any differences in change in hormone levels that were different than the placebo group. So the 2 green tea group did not show differences in hormone levels after the 2 months. What we did find, interestingly, was that there were changes in LDL cholesterol level and various glucose-related markers. And in fact, there is a nice summary of a meta-analysis done a couple years ago, and there's another one that actually showed that green tea seemed to have a beneficial effect on total cholesterol and LDL cholesterol. And there are a number of mechanisms that's been suggested how this might be mediated. And what we actually have oh, sorry, I forgot about this study. So because of the findings in breast cancer patients, we also actually got funding to do a pre-surgical study using green tea capsules. So this was actually in 13 women diagnosed with breast cancer, and we gave one group about 35 days of green tea capsules between the time of diagnosis and the surgery. And then the control groups did not get anything, and they were all non-green tea drinkers. And what we measured in this study was breast tissue biomarkers changes, looking at cell proliferation, apoptosis, and angiogenesis. And what we found in this study was that the green tea group, even though they were only taking it for about a month, they actually show significant reduction in cell proliferation markers. And we didn't see it in the control group. So this was interesting, but we did not see any significant changes in apoptosis or angiogenesis. So we've been trying to get a second study funded on this in breast cancer patients, and we've been having a lot of difficulty. I also want to say that this is going to be a very nice study. We actually have been having a number of conference calls the last couple of days. My colleague at Minnesota, Dr. Mindy Cursor, has a very large green tea trial that is finished. All the enrollment and intervention is done. We have more than 800 plus postmenopausal women that took green tea for 12 months or not. And so we will have an opportunity in this study to really look at all these markers that we're interested in. Many of the markers, we are doing the mammographic density in LA, and we are helping with all of the analysis. So I think this is going to be a really useful study in providing information that whether green tea actually might have beneficial effects, not just in terms of breast cancer, but for all kinds of health endpoints. So this is sort of my summary on green tea. The EPI study suggests that it's probably okay. There's a lot of interesting properties, and hopefully from Mindy's study with her cross-sectional study, we will have a better handle whether these effects of green tea really would be realized in these endpoints. And that's all I have.
What
liver toxicity that they were looking at when they first?
All of the studies now is that if you have, first, you cannot enroll subjects unless they have normal liver function. One of the things that has surfaced with the cases, with the case reports of women with liver toxicity was that many of them were obese. They were obese for different reasons, including alcoholism and other things, that they had compromised livers to begin with. So I think you just have to be, I think if you're drinking green tea again, in the Japanese population and in the Chinese population that drink green tea, there is not these issues. But if you're actually being put on something because you actually want to lose weight or whatever, then you have to really understand what are the underlying health status before you put them on.
The reductions in insulin and glucose that you saw, were those related to weight changes?
No.
I did notice you had a relatively overweight
Yes.
population, like the average BMI was around 29.
Yeah, it wasn't.
It wasn't?
Yeah,
Okay.
but
Interesting.
I would say the study, I won't, because my study is small. Mindy's study with 800 women, and her study, the average, we will have actually about a quarter of women who are in her study that have BMI 30 and above. So we will be able to actually do stratify analysis to actually see whether these changes, first whether there's a global effect, and after if there's a global effect, whether there are subgroups of women who would actually benefit. And that's really what we wanted to do.
There's been a lot of interest in the urinary estrogen metabolites, 14 and 16 hydroxy. Did you or did Mindy look at any of that?
We actually are doing it in her trial in a subgroup of women. I did not mention, but in another one of these studies, in a case control study of breast cancer that I worked on with NCI many years ago, we collected urine samples. And actually in that subgroup of women, in the controls, we actually looked at estrogen metabolites. And there's some suggestion that the green tea drinkers have a ratio of those healthier estrogen metabolites. But again, the trouble with all of those studies is the numbers are small and the results in pre and postmenopausal women were not consistent. But certainly Mindy's study we will be able to look at that. Yes?
From your summary slide, it would look like if we're working with a fertility patient, we wouldn't want a woman to be on high doses of green tea if it lowers estrogen levels. Is that true? Is there anything about fertility in green tea?
Actually, there is. There is a study. There was an intervention study in Hong Kong, and I think they actually enrolled women who had PCOS, and I don't remember what they found.
Okay.
But yeah. Thank you.
Thank you.
Thank you.